very hard to decide which is the best terminology for all this. Anyway, these are the institutions where I conduct simulation training. On the left, top left, my hospital in Dublin. On the right, the famous red door of the College of Anaesthesiologists in Ireland. And down there, the simulation labs. This is a very nice setup for obstetric anesthesia courses. And we are delivering multiple courses in those locations. So I have no conflict of interest. The photographs of the learners were taken with consent. So I tried not to take photographs even off the internet. So the terminology, as I said, it's so... I look over there, actually. The terminology, as I said, it's so used interchangeably that I decided to look into the definitions, okay? So single-speciality, single-discipline, simulation-based education and training refers to training individuals in relation to unique skill sets particular to a specific discipline. Could be medical and subspecialties, could be nursing, midwifery, pharmacist, allied health professions, and so on. Interspeciality or cross-speciality simulation-based education and training refers to a situation where two or more, often medical, specialities train together, for example, anesthesiology and surgery. And then interprofessional, multiprofessional, interdisciplinary, multidisciplinary refers to a situation where professions from various healthcare disciplines learns about, from, and with each other to enable effective collaboration and improve patient outcomes. And in my presentation, I'll refer to it as simulation-based team training. So the single speciality simulation is focused on specific knowledge and skills, including material of little relevance to the other specialities. And it targets specialities where essential skills can be realistically simulating using equipment across a range of fidelity. It allows, obviously, the standardization of under- and postgraduate training. It often takes place in simulation labs and simplifies the logistics of organizing simulation training. Okay, so there are various modalities. I'm talking, first of all, about case studies and problem-based discussions. Obviously, that's a way of simulating real-life situations. Serious games, there is a picture here from... which one is the pointer? From the Euroanesthesia meeting last year. So it's another way of training teams in a fun and engaging way, combining learning objectives with game elements that require decision-making and problem-solving. Obviously, procedures can be trained using low, medium, high, virtual or augmented reality simulators. And then I suppose the gold standard could be high fidelity simulation training, which allows the integration of technical, non-technical skills and in the management of complex clinical events in a totally risk-free environment. So single speciality anesthesiology simulation-based training. And obviously I'm talking about anesthesiology because I'm an anesthesiologist, but it applies to other specialities. It's an adaptation of training crew to work in teams, okay? The concept was first devised by NASA in 1970s, and it was adopted for anesthesiology by David Gaba. It involves basically participants from one specialty taking part in high fidelity simulation, and the other roles are played by confederates, okay, by faculty. So in a way, it's a or unnatural way of training people. However, it gives people the opportunity to learn how to work in teams. And obviously, it allows the learning of fundamental skill sets. It allows the training of anesthesia and non-technical skills, various ways of communicating effectively, such as closed-loop communication, graded assertiveness tool. I pushed down all these references. Obviously, you can look it up yourself. I just thought it's helpful to know who have developed these particular tools. And also the use of checklists, okay, WHO, algorithms such as the ACLS, MH, anaphylaxis, difficult airway algorithms, and so on. So our group, as I mentioned earlier, developed a curriculum for simulation-based training in anesthesiology, and we identified the main clinical skills required for anesthesiologists, the main scenarios and domains which should be part of a curriculum training in anesthesiology. And I'm sure you recognize probably some of the courses you yourselves are, some of the topics you yourselves are delivering. Okay, so we developed templates for each program. So this is a template for an airway course. So with learning objectives, with KSA, knowledge, skills, and attitudes, with suggestion for simulation methodologies and tools, and suggestions for evaluation. In Ireland, we have a mandatory simulation training program for our trainees. They have to complete 10 courses before being signed off. And these are the single speciality courses. You can see we have anesthesia emergencies, a course called ARREST, anesthesiology related rare emergency simulation training. We also have pediatric anesthesia, obstetric anesthesia, intensive care, and these are all single speciality courses. The feedback from these courses has been very good. The program has been going on for more than 13 years now, and important, we showed increased confidence scores in dealing with various emergencies. This is the feedback from more than 1,000 participants over a 6-year period. So the evidence in relation to the outcomes of single speciality simulation-based training shows, first of all, level 1 and 2 Kirkpatrick outcomes. Therefore, people like it. They are satisfied with the content of the course. They feel like they developed the knowledge and skills required for their particular practice. And, I would say, these are level 1, so we are at the bottom of the Kirkpatrick pyramid. However, they shape the intention of people to apply what they learned in the simulation lab in practice. So it's not something we should ignore. Obviously, we are aiming for level 3 and 4 outcomes, and there is literature about essential anesthesiology technical skills such as airway training, cardiovascular bypass weaning, central vascular access, POCUS, and so on. There is evidence, obviously, that simulation education strategies perform better than non-simulation intervention in relation to level 3, changes in behavior, increased ability to speak up, and the role of virtual augmented reality and artificial intelligence is not quite clear. And I know Mark is a fan of anything digital or virtual. However, I think there is still a lot of research to be done in relation to this aspect. I don't know what I'm doing. I'm pressing too fast. Okay, so interspeciality then, simulation-based education and training. It's a vehicle for teaching, rehearsing, and analyzing interspeciality performance. And it improves the interaction and understanding of various specialities, in our case the surgeons and anesthesiologists, promote familiarity with the peers, and develops a culture of patient safety. Of course, some of the single speciality learning objectives are more difficult to achieve, and it is difficult to organize from a logistical point of view. So these are the other courses which we conduct in the College of Anaesthesiologists of Ireland. These are interspeciality courses. One is with surgeons and one is with the surgeons and emergency medicine. I'll just briefly mention this course. It's called the MASCOT course, Multidisciplinary Anesthesia Surgery Crisis Operation Training, okay? And when we developed it about 10 years ago, we looked for common learning objectives for all the specialities involved. An opportunity to practice and demonstrate speciality-specific skills, but also common non-technical skills. And you are probably familiar with the ANTS framework, anesthesia non-technical skills. There is a NOTS framework for the surgeons, and obviously these are the crisis resource management principles which apply to each speciality. The feedback has been very good, but important, the feedback has been the same regardless of the specialty. So, it's obviously a course. There is an outlier here, which I think someone was confused about the numbers on a Likert scale. So what we learned from this course, okay? Initially when we started, they said, oh, the scenarios are too anesthetic, okay? So the surgeons wanted more hands-on in the management of the critical situations. They also thought, oh, it's too general anesthesia. We want subspecialty training. We want plastics. We want vascular scenarios and so on. So we improved the course over the next few years. We simplified the learning objectives. We made sure the learning objectives were more clear, and we progress to this point, for example. Okay, so this is a course for surgeons, anesthesiologists, and emergency medicine, and everyone has something to do. It's mainly about non-technical skills. However, the scenario starts with, trauma patient. The vascular people will need to clip the bleeding vessels. The anesthesiologists will need to intubate. The emergency medicine participants are running the red code, okay, for massive bleed. And obviously, we get them to talk to each other, communicate effectively. Someone will need to take the leadership and so on. So it's a very complex scenario, but it just shows how, you need to involve people. You need to keep them interested. Otherwise, they are not going to buy in. Okay, so we are moving on to interprofessional or simulation-based team training, and these are pictures from my own hospital. The one on your left, you will ask, what's this? This is actually one of our anesthesia trainees. So you don't need high fidelity simulation equipment. So I don't know if he's biting on a tube. He's not anesthetized, but there is a way to make the bag moving, or as in the patient is ventilated. But anyway, that's a massive bleed scenario in theater, and this is in the simulation lab. So we do this training regularly with surgeons, anesthetists, hematology, transfusion lab, nurses, porters, okay, and it's been quite successful. Okay, so I suppose simulation-based team training is the closest to the principle work together, train together. So it means training teams as they work, so they perform safely when it matters the most to the patients. It is more effective for learning teamwork skills than training individuals separately. It is a model endorsed by highly influential healthcare authorities such as Institute of Medicine, WHO, the Lancet Commission. It is recommended by renowned experts in simulation such as David Gaba, or organizational psychology and team science, Eduardo Salas. I think he's the guy behind the concept which SEEPS, is it? Yeah. Okay, so team training strategies and interprofessional learning intervention have led to enhanced teamwork behaviors, clinical practice, and patient outcomes. And I think we are moving closer and closer to this concept of teamwork, team-based competencies, and team training. So this is the Lancet paper just published in 2022. You can see that they talk about competence-based training rather than time-based training. They talk about interprofessional education, the use of information technology, education, and then simulation and artificial intelligence. Furthermore, loads of these organizations, the OECD, the European organization, they recognize the limitation of professional development, which was traditionally done in silos. Okay, surgeons trained separately, anesthetists trained separately, nurses trained separately. And I was actually talking to one of the facilitators in our nursing school in Dublin, in UCD, and she said, nurses are never, undergraduate nurses are never exposed to the concept of team training, multidisciplinary, before they actually graduate, which is sad, really. All this should be included much earlier in the curriculum. So while acknowledging the importance of specialist knowledge and skills for handling specific specialty clinical function, these authorities are also highlighting the importance of transverse skills. So those in charge with the curriculum will need to identify transversal skills, common skills for all the specialty, and training should be organized accordingly. Okay, so, why do we need this training? Because we want highly performant teams in our healthcare. And a highly performant team is one which shares the same mental model. It's based on mutual trust and respect. And it is based on clear and concise communication. So if the external part of that graph is met, then we will notice in the team leadership, good followership, mutual performance of each other's action, the ability to speak up, and in general, an adaptable and good backup behavior. The good news is all this can be taught, okay? Because, we can teach teams to share the mental model during the handovers, regular updates, using various communication tools. We can build on the mutual trust and respect by, using nurses and doctors' names, for example. In situ simulation tightens that collaboration between the team people and team members, and obviously closed loop communication and so on. Okay, so which are the most effective, I suppose, methodologies, interventions that improve team effectiveness? So the top three appear to be training in crisis resource management, team steps or simulation-based team training, okay? And I'm sure you are familiar with team steps and with the crisis resource management as put together by Roll and GABA. Our tools-based training and organizational redesign are also important in order to improve team effectiveness, and Mark has alluded to that in his talk. So does team training work actually? Well, again, level 1 and level 2 have been largely positive, okay? So learners' reaction and the confidence and the self-assessed knowledge and skills and behavior have been largely increased, enhanced after team training. There is also evidence that for level 3 and 4 outcomes, for example, improved communication, coordination and cooperation, improved support, mutual support, and some improvements in patient outcomes. However, it is difficult to demonstrate patient outcomes in this quality improvement studies and after simulation. This is an interesting one. It's again the team of Eduardo Salas. It is a meta-analysis looking at the effect of team intervention on in healthcare, and again they showed a large effect for. They showed. I don't know where the laser is. Is that one? Yeah. Okay. So they showed. Thank you. They showed a large effect for learning and for a transfer of learning to the real practice, and a lesser moderate effect on organizational outcome and patient outcomes. More importantly, they showed a sequential outcome here across the levels of the Kirkpatrick pyramid. So basically, improving reactions will lead to learning, which will lead to transfer, and which will lead to results in the clinical practice. This is, an interesting paper which just came last year from New Zealand, and it shows that team intervention improves patient outcomes. It's a meta-analysis. What they did, they said, okay, you cannot do educational research, you cannot do quality and safety research using the traditional methodology of meta-analysis. So they included not only randomized controlled trial or pre or and post trials, but they also used large observational trials, and they were able to show a impressive reduction in the mortality by 28%, and less risk of adverse outcome by 23%. You may say it's controversial, maybe it is, but there is little a good quality research to some kind of convince us that the team training is effective in healthcare, and it's so difficult to demonstrate that. Okay, so simulation-based team training involving anesthesiology staff. The research is not so extensive, I suppose, but there is some research showing increased knowledge and confidence after MD obstetric emergencies and MD airway management training, and also another paper showing that simulation-based team training involving anesthesia staff increases the awareness of teamwork and non-technical skills and improve communication and decision making. And finally, a cardiopulmonary arrest mock code with anesthesia participation has improved the pediatric survival rates and remained sustainable over next year. So finally, I'll be briefly talking about in situ simulation. It's the closest to work together, train together principle. And although these papers all have shown that actually there are similar individual and team learning experiences in situ versus off-site simulation. There are pros and cons for in situ simulation-based team training. But, you know, the most positive impact is in relation to testing systems, equipment, procedures, and all that which you heard about already, and identifying latent threats, which would become obvious only if a critical event took place in the working space. So again, in looking at the outcomes, there are studies showing level 1, level 2, and level 3 and 4 positive outcomes along the Kirkpatrick pyramid. So I'll just finish off with key points. I think single speciality simulation-based education and training provides a strong foundation for acquiring the necessary skills for each individual speciality, and is forming the basis for interprofessional clinical practice. Interspeciality simulation-based education and training enhances the mutual understanding of roles. It builds up respect and understanding, and a common commitment to patient safety. And then interprofessional simulation is widely regarded as the gold standard for team-based learning, collaborative clinical practice, and enhanced patient outcomes. And, you know, I went to see both these guys, David Gilmore and Roger Waters. But, you know, when I went to see them both in the concert with The Wall in Dublin, it was just a different thing. Okay, so thank you.